Welcome to the Center Collaborative, Creative Solutions in Behavioral Health and Criminal Justice, brought to you by the Oregon Center on Behavioral Health and Justice Integration, which is also known as the Center. We at the Center are all about solutions. Our job in Oregon is to facilitate improvement of the system so behavioral health and criminal justice can work better together to engage people in treatment while promoting public safety. I am your host, Chris Thomas. I hold a master's degree in clinical psychology and have focused on the intersection between behavioral health and criminal justice for 20 years. Over 7 of those years were behind the walls of a maximum security prison. During this podcast, you will have the opportunity to sit in on real, in-depth conversations with experts about complex topics in a way that is both fascinating and digestible. We will focus not just on what is wrong with the system, but what is going right and how we can work together to evolve. In this episode, which is part 2 of a 2-part series, I'm joined by Kevin Fitz, Executive Director of the Oregon Mental Health Consumers Association, to discuss what peer respite centers provide to consumers, filling the gaps by providing services that aren't covered by Medicaid, redefining workloads in the system to include more peers and the importance of peers within policy groups, how peers help build community and long-term supports to bolster hope and to support wellness. We also discuss the need for more damp and wet housing in Oregon. Welcome to our conversation. This is such an exciting program, and I am thrilled to hear of the BIPOC diversity aspect of the bill. I'm curious, with this being a pilot project with 4 places.
So just a point of clarity, only one is a pilot project. The rest are just going to, as far as our legal counsel, ongoing, funded into the budget. The pilot project will be the BIPOC pilot, trying to tweak it, shape it in ways that may better meet the community's needs, so it's not set in stone. Of course, myself, and the other volunteer that works for my organization, it's not up to us to shape what that service, what that peer respite house looks like. Let the people whose community that it purports to serve help administer and shape that. And that's why I think calling it a pilot gives it some flexibility in its definition.
That makes sense. Thank you for the clarification. I'm wondering if there's been any conversations around metrics to show how effective having options on the 2nd and 3rd floor are, that if there's been any talk about that with data collection around being able to show the legislature in the future how helpful these peer respite placements are, and if there is the possibility that it could help grow it in the future.
Yeah, so that's a good point. When the peer respite initial in the 2019 legislative session, it passed the health committee, which at that time was tasked with the behavioral health bills. The chair of the committee said, we passed 3 of these today, but ultimately I think there ought to be 1 in every county in Oregon. I think it's so needed and so fundamentally important. And this was the chair of that committee, didn't know anything about peer respite until 3 months before when we started talking to them about it. One of the things that I think about is, how will we know? The point about that is, so we did initially think maybe we should write some money in this for research. We didn't do that initially, but there has been some discussion is maybe we come back to the legislature in 2023 and say, we think we have a gold mine of a great narrative that I think the rest of the system can learn from. I also think that if we did some more longitudinal research, qualitative, to see how's this reshaping our understanding and our engagement for folks in intermediate psychiatric crisis that are still at a level of self-management and voluntary supports. What does that look like? And so it is in our mind. One of my board members works in research at our local university. And so we're thinking about how do we formally get the message across? And that would be whether maybe they're tasked to write a report on it, or to look at outcomes, or to do a survey, or What exactly? Not really sure what that is exactly. Like I said, we're now in the project with, okay, state of Oregon, here is the law that I lobbied to get changed. It was changed. Now you have the responsibility of, one, putting together, by the way that law is now defined, who are the apropos contractors? Where are you going to draw the lines between different regions? Is it coastal area? Does that mean it has to be a beach town? Could it be Tillamook, who's not technically a beach town? Or could it be set back, or Eastern Oregon or Central Oregon? How close should this be to a hospital or a community mental health clinic? Are there contractors? Definitely there are contractors statewide, multiple contractors statewide that could do it, but are there local contractors that are region specific that may have more plugged into the culture there that may be interested in maybe such criteria? All of that has to be settled out. And then also too is, we know the state of Oregon knows how to site residential treatment facilities and secure residential treatment facilities, where some have locked doors, some have massive computer files of Medicaid billing and medications and et cetera, et cetera. But how, when you have something that's not like that, how do you set it up? How do you presume and take care of liability and insurance and all those sort of different things? Because never had something like this come through the state administration. There's been Multnomah County. I first got this idea because I was working for a nonprofit peer-run organization, and they just rented a house. They paid the rent on the house, and they had staffers there 24/7, and it was people that were in services on their ACT team, but they were also, when they were going through challenges, could stay at the house for anywhere from a day to, I think it was a month maybe or something. But we didn't call it that. It was a one-off sort of thing. But that was somewhat of the idea of, particularly because these people were previously very high utilizers of the psychiatric crisis wards in our local hospitals.
Could you talk about that house a little bit more that was in Multnomah County and what that intervention looks like?
Yeah, so initially it was funded through, speaking of pilot projects, the federal government funded approximately a dozen pilot projects around the country to help support, and this was in 1988, I think, to help support the development of consumer-run initiatives. They didn't use the word peer back then. Advocacy projects, service projects, etc. So one of those things came out of that, was developed in Portland, Oregon, a place called the Mind Empowered Incorporated, which from the top, from the executive director to the psychiatrist to everybody identified above board as a person with lived experience of mental health issues. That organization started out as a community drop-in center, open 10 hours a day, 12 hours a day. And then one of the things that happened was that they got more money from the state, who was very interested in looking at some of the ways they did things, to fund a ACT team, assertive community treatment team, run by mental health consumers for mental health consumers. And a lot of the initial referrals were people who had dropped out of conventional services or had been denied because they were difficult to treat, non-compliant, such things. So they ended up on the doorstep of this one case management team, which I think they had 15 or 20 clients, and I think they had 2 different teams, so maybe a total of 35 or 40 clients. So when they were realizing, what do we need in our toolkit, what do we need to help serve people that doesn't exist, was that they realized, instead of, if someone they were working with, either in their apartment or their single room occupancy hotel room, was having a struggle, that if they could come stay at the house for a while and have some more community, be checked in on more regularly, and make sure that they were having meals delivered to the house, so that they were getting fed, that might be a stopgap for some of those people ending up the next day at the emergency room. And so that's what they decided to do. We're going to rent a house in Northeast Portland, and we're going to be the landlord, and the only tenants will be people on our ACT team. But not as a long-term residence, but it's only for when those people are going through extreme states or much greater challenges than they might ordinarily be struggling with.
It seems like it touches on all those things that people really need but aren't covered by Medicaid.
That's right. The two times that I've introduced this bill, doing two different legislative sessions, when I've written down what is the problem, what is the solution, how much was it cost, and hand that paper in to a legislator who will say, Kevin, I will take this to our lawyers and they will write this up in legalese. It has come back, the initial draft, both times, provides seed money to fund a Medicaid support house for people in psychiatric crisis. And I said, no. We're not talking about seed money, and we're not talking about a clinical setting where clinical services or assessments or med prescriptions will be handled, whatever. This is not what we're talking about. In the way that it's currently set, in the way that our arrangement is with the federal government around Medicaid, we're not set up to do that sort of non-clinical and get Medicaid supports for it. We might be in the future. Hopefully, there's lots of us who hope that there will be opportunities to reshape what we're able to bill for or not bill for. But currently the way it is that you can't do that with a non-clinical house with just peers. We're not talking about mental health professionals, for people who do chart notes and administer medications. That's a different thing. And like I said earlier, so many people didn't even know, they've never heard of such a thing and never written a bill or even written a larger bill where this issue was ever addressed or talked about. The first time peer respite as a word was ever introduced in the Oregon State Legislature was 2019.
For me, when I'm listening to this, it makes me think about filling gaps, right? So the traditional services are there and the services covered by Medicaid are there and they serve a purpose and they do a great job in that purpose. And yet there is this gap that these peer respite centers are filling around community and social determinants of health, and being there when someone isn't at the far end of the continuum in order to support someone before they get to that far end of the continuum. And so for me, it's not an either or. For me, it's how do we fill gaps where we're able to provide services for someone where they are when they are reaching out for help before someone gets to a point where they're in crisis services that are Medicaid funded. Is how I'm wrapping my brain around it.
Yeah. One of the things now people say or ask me an awful lot, what do you think the role of peers are going to be in the future? One of the things that worries me fundamentally, beyond just hopefully getting this peer respite thing and making it a useful service, another thing that worries me significantly is the workforce issue. And how are we going to be able to bring enough, I don't know how much money, $200, $300 million this legislative session alone, maybe more, to workforce issues. Whatever stories we want to tell ourselves about bringing more nurses and QMHPs like we had it 10, 15 years ago to rural or frontier areas, I think is just absurd. We need to reshuffle the deck and reconfigure the way our community mental health services system is delivered based on our absence of our returning workforce. A friend of mine used to run a national organization, the Association of County Mental Health Directors. And he suggested, now he's probably a little early, by 2020, he thought 30% of behavioral health service employees in the United States would be peers. I don't think it's going to be that much, but I think you're going to see a radical restructuring of the QMHP's role, the role of all social determinants, issues, and responsibilities, and what can be front-loaded on the qualified mental health professional's desk, but what is absolutely essential that needs to stay there that can only be done by a person of that role. But what else can be parceled off? And I think you see fundamentally systems readjusting themselves. A friend of mine at a CCO said, we are hemorrhaging. They can throw all the new money at it as possible, but we're never going to get the amount of workforce retention and redevelopment. That's never going to happen. So we need to crack open a blueprint for the way that we're setting this up. Something's got to break because we're pushing a model that's not sustainable. And we're never going to get the amount of employees that we're hoping for. And so I don't know exactly what that looks like. Some of the things they were talking about, imagine if there was one 24-hour, 7-day-a-week telehealth prescriber, whether there was one facility that anybody in the state could go and get a psychiatric assessment and maybe they needed a med check or something. But there was one central location where you didn't have to go into a hospital and have to meet criteria and get assessed before you talk to a psychiatric prescriber. What happens if there was something like that available for anybody and everybody around the state? Just a whole bunch of other things that think about how could we reshape this if we're not going to have the amount of workforce that our systems are set up for.
We've heard so much interest in more telehealth, particularly around COVID, but also with incorporating working with more peers in the community, particularly with the center. We specialize in the forensic realm. I'm wondering if you could talk about that a little bit around where that is helpful and how that looks different to have someone who specializes more in the forensic realm in working with peers.
I think fundamentally the leadership, and I've been saying it for years, is the voice of the person who have used such services needs to be elevated. I'm glad that you have people who work for this community organization and have this master's in public health and a PhD in anthropology and or whatever it is. But where if one of the goals and one of the things that they say is predominantly we want to address the issues of racial injustice and discrimination and racism in our criminal justice systems, how can you affect to address criminal justice and the racism in our criminal justice system if you don't have somebody who has been through the grinder to talk about it? I think there are people who have behavioral health issues or whatever, but I thought you're still dancing around. In fact, I brought a young man who was just freshly out of Eastern Oregon, one of the Eastern Oregon prisons, who also struggles with behavioral health issues and substance use, to have a conversation with the coordinators of that board of saying, we think it'd be great if you had some courage to say, you're putting together the stakeholder committee purportedly of our voice, but I don't know where our voice is at the table. Maybe 30 years ago, the guy that runs this $5 million African-American service organization may have had some run-ins with the police 30 years ago. But since then, he's been an administrator and a professional. How are you going to be informed if there's nobody fresh from these experiences at the table who are above board about it? Without having leadership by the people who have gone through the systems and giving feedback to the people who set these systems up, I don't know. I don't have a whole lot of hope for it. The systems continue to make mistakes because they really are underpopulated with representative voices of those communities. That's one of the most unfortunate parts of our system is where is the leadership that's affected by this works best for these people? And that really is a trouble spot for me. It really burns me because it has affected a significant amount of younger friends of mine in the BIPOC community who are, at least here in the metro area, that's mostly I'm familiar with, have failed them so much and seen the path of try to engage in services and to see it fail, particularly somebody who's very close to me over and over again, 3 different times, and then end up the criminal justice system, just like, man, oh man, saw it coming. It was just very frustrating.
Yeah. I'm keeping an eye on the clock and I'm wondering if you want to spend the time talking about any other interventions that you've heard of that you think would be helpful in the system that we haven't talked about, or if you have any last thoughts for our listeners.
Yeah, so I'm on a kick. The 3 things on my mind, the goals that I've had over the last 10 years is 1, try to see the opportunity to help create professional level peer manager jobs within a county administration. And then following that was, if our coordinated care organizations are the main parties responsible for the brokerage and the definition of what services look like and what are buying, I want peer services. The goal was to make sure that peer services, if you qualified, was a right to you as an Oregon Health Plan client, that you had a right to a nurse and a psychiatric prescriber and maybe a skills trainer if you meet the criteria for it. But also to let people know right above board, also too, is if you're eligible, you could also get peer supports. And then the third part of that was trying to shape and move forward this peer respite. What I think about in the future is not really clear, but one of the things I'm really thinking about is and I've started doing some investigation in some of the psychiatric reform movement in Italy in the 70s. I'm really interested in what long-term supports look like and what a mixed community may look like. I got this idea because I heard a public radio documentary talk about a place called Giel, Gheel, Belgium. And purportedly, Giel, Belgium has been a place, at least for 500 years, 600 years in the Middle Ages, that folks struggling from severe mental health challenges would find their way to. It's also been purported that Van Gogh's brother or family member suggested maybe he go there. There's a story about a Catholic saint named Saint Dimfa, who people go there to have intersections or to connect with her. One of the things that fascinates me about the idea of Giel is it was a small town, but there were people that were in the hospital at night, but during the day they were let out and interacted with the community. That has inspired me to think, what would a long-term small village look like where you had peers and mental health professionals, but also had consumers and clients living within the community, and everybody lived there. I don't know what that actually looks like. I don't know if anybody's particularly done that. I don't know whether that would be in a large city or that would be in a remote area. I don't think either one of those makes sense, but I'm still in my head trying to think about what that would look like, and would that be of interest for people who may be burned out with working in some other conventional service program. So that interests me. Why that interested me is because one of the things that I really am more and more in my mind is the idea of that long-term community, ritualized expectation of people who know you, who you value, who you have some trust to, and an ongoing connection with them, I think, for me personally, has made such a huge difference. So I know an awful lot of people who work in conventional mental health services, and I'd say 99.9% of them are excellent and care very much about the people that they interact with. However, I do think that we have a shortage, and even in my short time of working in public mental health services from the late 80s, is that our community connections with each other, let alone by the development of Amazon, the internet, and all of those things, has shrunken our community contacts. And then throw on top of that COVID. But what does that look like? Having repetitive, meaningful community that interacting with the same people, not transient. You go to the psych ward, you're there for a week, you interact with people who are nice, and you make a friend or two, but you rarely see those people ever again, most of them. But what would it mean to be returning to living in a community where you had some expectation that the people that you saw would know you, and this would be long-term relationships? I don't know exactly what that looks like, but I do really think that people are starving for community. People are dying of loneliness. There's some people who struggle, who have no family, who have no partner, and are currently all of their only friends are people on the ACT team that come in to do a welfare check and give them their med pack for the week. What is the quality of people's lives like that? And so I'm not really sure. It's not formed, but I continue to think about what long-term co-village thing may or may not look like, and who's got some part of that looks interesting and looks worth sampling or trying out.
It makes me think of folks in a program, right, like a mental health court, and they have all these supports and services, and people really know them, and then mental health court ends, and all those services and support in that community goes away.
Exactly. Just like ISA. Yeah. Like you have this great wraparound services. I don't know what the cutoff date is, but yeah.
How do we continue that sense of community and build hope and meaning as a way of continuing support, instead of having a program it ends and then there's no continuing support to continue to go on? It's just, okay, this program's ended and all that goes away.
The only thing that rings the alarm bells is a public safety issue. Yeah. Loneliness, quality of life, quantity of life. If everything else is reduced down to public safety issues, then the programs pay for them, and then the services sunset. And then, hey, you're out there alone, atomized, until things start to escalate or catch fire, until you're in horrible shape again, and maybe you'll end up back here. It's a feast or famine sort of thing. But also, undermines what is the goal. One of my friends is a psychiatrist who says, shouldn't the goal of the mental health system be to meet people's needs where they're at? Instead of wait until you get your needs met, like you're trying to cook an egg or something, you need to do it for 5 minutes or 4 minutes or whatever. I wonder what could be created if there were earlier opportunities for engagement that met people's needs. And then also too is I think I have some of my best friends are psychiatrists. Every door that you knock on in public mental health when you're hurting and in pain does not need to be met with, here's what it says in the insurance coding classification manual. You have beep up up disease. You take pill number purple blue one. Okay, I totally think that we have a system that sometimes engagement is making a connection, finding a safe place to sit and feel unthreatened. So I don't think that every door you knock on should be met with the same process and procedure. And sometimes just making a contact and providing somebody with information is maybe all they want or all they can handle at the time. I know that people have gone to local walk-in psychiatric clinics to get a med refill and ended up with new diagnoses and worrisome trouble things that they weren't even asking for. And so that sometimes people find it very, being 19 years old, and the first thing you're told is you have this horrible diagnosis and the prognosis ain't so good, so get used to it. That's just there need to be other doors. It was like, hey, welcome, take a load off. God, it's hard struggling with this sort of stuff.
You're not alone.
Right, you're not alone,
Yeah.
and you don't have to go through this by yourself.
Yeah.
And we mean it. We don't have to 24/7, 7 days a week. You don't have to go through this by yourself, even if there's only a little bit of challenge, or I don't know. It's frustrating to me. I also do think, and I don't really know how to do it, but if I go to you and you're in some of our larger places in the metro area are combining care, like we want to do your primary care and your mental health care, how can you not? Now, I know that Medicaid doesn't do it at the time, but if I had the power, I would like to say everybody who sees somebody who's on the Oregon Health Plan who has behavioral health or SUD disorder that's houseless, we should pay for their housing, because to try to promote well-being and getting symptom management and move your life towards wellness, it's really hard to me to understand how does that take place where you need to move or you're sleeping out someplace where people don't want you. How in the world can we be trying to provide holistic care if the safe place for rest and well-being and there's no safe place to lay down? I just think, I don't know exactly what that looks like, but I think it's a huge issue here in Portland. Every time I travel around the core city, I see people, I'm thinking, how much less challenges and less pain would that person be in if they had a predictable, safe place to go and stay every night that didn't come with mandates. You need to accept, this is what this says about you. But it's really difficult, because trying to address a person's behavioral health and primary health without talking about there's no safe place to sleep ever is like fixing 3 flats on a car that has 4 flat tires.
Or that someone has to be not using substances in order to go somewhere. I know we hear about that over and over again. The lack of damp or wet housing in Oregon, where most of it is dry housing. So you're asking someone that this is how they're coping, that this is part of what's going on with them, to then all of a sudden stop in order to get help, and how that doesn't really seem to work for a lot of folks.
There's a big discussion I've been having with some folks in other states. One is, what's the expectation of complete abstinence? How many people get churned in and out of certain residential or housing places because of failure of that? And how does that collapse or cause catastrophe in the rest of their domains of their life fundamentally? What does it look like to think about? We provide shelter and food, and then therapeutic engagement comes next. I don't know if it's still the same, but there's a very large organization in Vancouver, BC, that used to be in their mission statement was, our first mission in this area is to provide housing and food to people to the degree that they want to engage in therapeutic benefit for themselves. That's their choice. And that's not going to be a mandate of housing. Of course, it's not glamorous. You're living in a 8x10 or a 10x10 place with a cement floor. Of course, it's heated, but with no, you have to do this or you have to do that or you have to do this. But if not, we're going to throw you out the back door. And even there is a certain hypocrisy in our systems where we say, some of our places that say that we're not absolute about it, and we try to make concessions. I know an awful lot of people who were chewed up by that issue. But on the other hand, I also know a lot of people. I have two good friends of mine that their addiction to opiates ultimately ended their lives. So it's very challenging. But I do think we need a panoply of different approaches. And I think we have a very limited sort of imagination of what's possible. And I think a lot of that has been set by thinking that came out of the 1960s and 1970s.
I'm excited about new possibilities in Oregon.
Me too. I am excited about
Respite
it.
Centers.
Yeah.
Yes. And I will be thrilled to hear how it's going. I'm hoping that you can come back in the future and chat with us more about how that is going and other interventions that your organization is supporting in Oregon, because y'all seem to be on the forefront of thinking about how we can do things differently.
Yeah. One other thing that I was somewhat involved in talking about the internet is the development of an amazing resource that's currently funded by the state of Oregon. It's called peergalaxy.com, all one word. But this took place in the discussion of early COVID with some key people at the state of they're locking everything down. Community clinics are shutting down. Community support groups are shutting down. And what it is, if there is an online support group or online supports, individual or group, for folks with behavioral health issues, problem gambling issues, domestic violence issues, SUD issues, cluttering, hoarding issues, et cetera, that it is cataloged and that there's a daily calendar at peergalaxy.com. And amazingly, I think it's gotten over 3 million hits or something in its short time that it's been alive. It's just phenomenal. And the things, in speaking about research, how do we know how many people have connected to an online support group that has changed the trajectory of their wellness journey in the following couple of months, where some of those people have been acute care customers had they not found some way to get their needs met in mutual self-help support groups online from their home computer and made some new friends. So I just think that's phenomenal. And I just think that's maybe even for the younger age, I think it's going to become even more of a way of trying to find out how does new technology offer opportunities to make friends and build community. That's ongoing. And I think Pure Galaxy does it phenomenal. My friend who runs it, other states are already very interested in it. And they have national listings there too as well.
Ongoing and on demand, where you don't have to find a ride to get somewhere. It's as easy as just turning on your computer or turning on your smartphone, right? Yeah. Any other last thoughts, Kevin, for our listeners?
No, I don't know. I don't know. I'm always interested in that which I'm extremely curious, and I'm always interested in what moves the needle. What are other places doing? Like I mentioned Vancouver, BC, but what are Northern European countries doing? What are people doing in Italy? What is not in the mix that Oregon is doing, particularly in public mental health services, that other folks are looking at differently? And I love learning about it. I like listening to new ideas about it and looking at other projects and then trying to educate people in an accessible way about this is what peer respite is. This is what open dialogue is. This is what Hearing Voices Network is, stuff like that.
The curious soul in me sees and appreciates the curious soul in you, Kevin. Thank you so much for coming on the podcast. Sure. It's been a joy.
Sure. Very good. Thanks so much. I'm very excited. I'm just a total believer in media and communication and getting the message out. And I've been a big fan of the Gobi, just the general organization for years. I love the leadership that Gobi has currently. Just a big fan of everybody.
I'm really glad to hear that. They are a joy to work with, and to support us in this podcast has been amazing.
A shout out to Karen Wheeler, or is that too?
Oh, please do.
A
Yes.
big shout out to Karen Wheeler.
Yes. So for our listeners, Karen is our CEO, and I used to work for her at the Health Authority too. I worked with her a number of years ago before I came to Gopi, so it's been a joy to be able to work with her again.
Awesome.
The Center Collaborative is a production of the Oregon Center on Behavioral Health and Justice Integration, a specialized division of Greater Oregon Behavioral Health Incorporated. It is produced by me, Chris Thomas, with production assistance from Patrick Kennedy. Music by Patrick Mulvihill and Patrick Kennedy. Subscribe to the Center Perspective using your favorite app. To learn more about criminal justice and behavioral health in Oregon, visit the Center's website at ocbhji.org. You can also find us on Facebook. We'd love to hear from you. Please reach out to us. Join us next time as we chat with the experts about programs and partnerships at work within this complex and yet compelling field.